Welcome back from the coffee break. My name is Lena Hellström-Vestas, and I'm very happy to introduce the first speaker, who is Nikk Conneman. He's a neonatologist from Rotterdam and a well-known NIDCAP Master Trainer and also APIB Trainer in Rotterdam, where he's also the director of the Sophia NIDCAP&APIB Training Center. And he's also involved in the FINE program as a program board member and trainer. And today he will talk about when the baby tells us about well-being from a Synactive model perspective.
Last year I was at this conference and then Kajsa Brimdir, the ethnographer who also advocates skin-to-skin care and zero separation after birth, and she does amazing work filming births around the world actually, and I really admire of her work. And she said that, and this is very important, I think, if you remember one thing, maybe you have to remember from last year, that she said all behavior of the baby after birth is geared up to going to breast with the mother. And for premature infants, this is the same, only it takes longer for a premature infant to reach that state at the breast. So for me, these two quotes really put it all together. I was like, wow, that's, you know, the premature infant doesn't need to have all these qualities right after he's born prematurely. I mean, he needs to, you know, to develop, and we have to be patient in that development. And so what I'm going to talk about is what Heidi was talking about this morning, because when that speech started to happen, I'm like, okay, I'm second act. So I will explain the Synactive theory to you. And a lot of people already know this Synactive theory, and hopefully I can have a little nugget here and there so they can teach their students even better after they've heard me. When I was working in Boston, I was working as a developmental specialist. This was more than 20 years ago. And I was working with the mother of this baby, and she was very much afraid that she would never breastfeed. And so I'm very pragmatic. I'm like, okay, we'll see if your daughter is up for it. So we prepped the parent room. We made it really dark. We did have color in those days, but because it's so dark, it looks a bit, you know, black and white, but, you know, vintage. And what we did was just bring them together. I never said we're going to breastfeed. No, I just said, let's see what she's up to. And I think this is a very important given, that our expectations need to be put on the shelf a little bit. If you expect things from a baby, please don't. Stop doing it. Stop expecting things. Invite the baby in a situation and see what the baby wants to do. It's the same for toddlers. In my outpatient, I usually sit on the floor and I play with a 1-year-old or a 2-year-old. And I never forced anything on them. I just see what they will do. And if the baby wants to stand up erect and follow along my examining table, or just wants to do this with the mummy, you know, you don't have to do exactly what I say. So the thing is that I often use, and there's no sound to it at the moment, I'm not sure, but anyway, so the mom is really cooing, and this is a beautiful moment where you can see the baby opening her eyes just for a little glance. She's holding the mother's finger, and she has a latch, but she's not sucking. She's just hanging out with the with the nipple. She is sort of exploring. And you go back to Kajsa's other tapes where the bigger babies are, and this is part of going to breast, just exploring the nipple. And of course, we had this baby, it was in the intensive care unit still. She was about, I think, 31 weeks old when we were doing this. And she's on a saturation monitor. And at one point, we have a false alarm, and the mother looks up. For me, I use this image to show bonding. This is when mother looks up, and then she sort of loses concentration of her daughter. She moves her left arm, and then the daughter comes off the nipple. So you see how much energy it takes for mother and daughter to connect and to stay connected. And, you know, she's done enough, and that's okay. She never gets back onto the breast, but, you know, within a week she was breastfeeding at least twice a day, and from there we progressed to all breastfeeding while leaving the hospital. So the thing is that apart from the beauty of mother and daughter being together, I think it really showed the bonding situation of the connection that the mother had with the baby and the baby with the mother. It came up this morning that the baby is developing, and the amygdala of the baby develops around 33 weeks in the womb still, but the hippocampus connected to, you know, all the impulses that the amygdala can give while in a stressful situation or in any situation, that amygdala is active in the incubator. And in the incubator, you know, you want mother's body and breast. In the unit in NICU, you want the mother to be surrounded with her social group. And these are intricate developmental steps that are really needed. So the term baby can be with the mother continuously, and hopefully through the work of also Stina, we have serial separation, and that the preterm infant can lounge and learn and enjoy and sit there while the amygdala is taking on this environment and coping. And this is where we will emphasize why we're giving this talk actually. This morning, Heilise was talking to us, and she also said developmental care understands each infant as an individual with unique strengths and competencies and with unique thresholds of stress and disorganization. When I teach, for instance, the family infant neurodevelopmental education, the FINE course, sometimes people come up to me and say, do you have any tricks and tips I can use? And nothing gets me more rattled than somebody asking me for tips and tricks. There are no tips and tricks. There is only you opening up to the baby, and the baby hopefully telling you what the baby needs. And this is what we're working with and on. And Heilise also emphasized, says that the baby develops in interaction with its environment. So the environment is pretty much, you know, setting a stage in which the baby lives. So the environment of the womb is this space where the baby is held the whole day and night and weeks and weeks. And if the mother has a decent life where she's being fed, where she doesn't have extra stress, that is an ideal environment for, if the placenta functions well, for the baby to grow up and for the brain to develop. Until the birth, and then, you know, at birth the baby has another influence of this bright light coming up, and then hearing a sound that she was sort of used to, but it sounds different now, and then there's this body, and then there's this smell, and then there's this drive to find something that the baby is, you know, for the first time aware of. It's that nipple, and the reflexes help the baby doing that. In the whole thing, what I want you to learn today is how do we look at the baby. Sometimes we can look at the baby and say, oh, the baby's upset. Now, in my teaching, I don't want you to make that assumption. I want you to tell me why you think the baby is upset. So that's why I'm introducing the autonomic motor state. Heidi talked about it this morning in more detail to you. So when we're talking about the autonomic system, the system that helps you breathe, the system that regulates your blood flow, and also your visceral system, your digestion of the milk you're receiving from your mother. So what is unique about our system, our care, is that we actually stand at the bedside and we look at the baby. Now, let's see if I can get this to work. Ah, right. So we stand at the bedside and we just look. Some people say you do nothing, but that's not true. we actually look at the baby, and I invite you to just look. And the NIDCAPers in the audience will automatically start looking at the breathing and the quality of breathing. The color is always a bit tricky when you look at a video, and if you have a monitor system, then you could see the heart rate, and you have the nursing notes, so that you know something about how the baby is feeding. The thing is that breathing is a very delicate instrument in which you can see, how is the breathing? Is the breathing pausing? And why does the breathing pause? Is the breathing going really very rapidly? Is the color of the baby changing? And it's not the way that we teach our students the color of the baby. The baby is pink. No, it is what part of the baby are you looking at? Is it dark patches under the eyes? Does it have a bright white nose? Or there's a red streak? Or there is some really darkness or mottled skin? We have a very elaborate collection of describing what the skin looks like. And then there's the gagging and the gasping for air. So there's a lot going on, and you can see it and appreciate it by just looking at the baby. Also spitting up. Sometimes, we think hiccuping is normal. They say, oh, he's just hiccuping. And I'm like, maybe the care was going a little bit fast this time. And did you have a connection with the baby? Why is the baby hiccuping eventually? Or bowel movements. I remember the mother of the baby you just saw. We would do demonstrations in how you can take care of a baby while holding skin to skin. I mean, way back when, I'm talking 24 years ago, we implemented skin to skin care in Boston in the big unit there in Brigham and Women's. So I was demonstrating how you can do a side-lying diaper change while on the mother. And then the baby would poop when I opened the diaper. And the mother said, oh, she's pooping. You can do this more often because she has a little trouble pooping all the time. And I was thinking, oh, am I going too fast? Is there some stress happening here? And so you want to be aware of all these behaviors, the autonomic behaviors. And then there are the little tremors. When you look at a 24-weeker, he has no muscle power really to work against gravity. And what you see is usually a very reddish individual that has these sort of small, maybe little tremors. So the autonomic system is still not working properly, and then you want to be very aware of that, and of course the baby's not going to open his eyes or do other things, but positioning the baby well enough so that the baby can sleep, going very slowly during your care, is what that baby of 24 weekers needs, for instance. So what we're aiming for is a self-regulatory behavior, is a well put together skin color, regular, steady breathing, good digestion, and that's what we aim for. That's what you in the long run will see in the baby that you care for in the NICU. Then we have the motor system. So the motor system consists of looking at the tone of the baby, and the posture. Is the baby sort of flat out on, like in the old days when they were totally overstimulated and they would lie there as little froggies, as they were called in the days, and they would have no tone. And this, I hope every movie works, but I'm so scared now. Oh, shit. So you see the baby here, and he has the hand-to-mouth movement. There is this hand-to-mouth going on, but as you've already appreciated, she's lying on their back and being arched out, and there are lots of these crawling movements, and this is a very short video clip. And can I run it again, hopefully, maybe? Yeah, oh no. Well, maybe it comes up again. But so there are these movements, and what I see is a baby who, is disorganized motorically, but there is this island of trying to modulate himself by getting the hands to the mouth. but not succeeding because the baby is still, not there in the development. So that's where we come in as developmental specialists. We notice that the baby's trying to do this behavior, and then we sort of use our voice at the bedside and say, hello, I know you really look upset, and I would be upset too if I were lying under the beely lamps all morning, and maybe you're a little hungry or you've had a poop in your diaper, and we'll see, And sometimes babies, they react to your voice and they will slow down in their movements, and when he does, then, you put your hands in the incubator and you sort of place your hands on and say, hello, let's do this together, and so you try to modulate the movement of the pelvis. I always start with the pelvis instead of most people, they try to yank the head like this. Don't go there. Just place the pelvis in a flexed position, sort of reminding them of the womb. And then usually they slow down and there is more flexion coming in the rest of the body. It should work. It hopefully works, but not always. But and then you go and you remove the iPad and you turn the Billy lights off, and you sort of wait for the baby to settle and see if he can find his hands by himself. And if he doesn't, you can try to move the hand to the mouth and see what he does with that. And then you sit there and you breathe with the baby and you say, oh, that's a job well done. And that's how you play with the baby. We had some playing, and it means you support the baby. So as I said, hypertonicity, the hyperextension, is a way to see that there's disorganization. It can be the arm, the legs, they can, when they're lying on their back, they can stick out the legs up, and it's like they're sitting on air, and they're stuck. Their system cannot tell them to bring in the leg yet. In the womb, they could stick out their legs, but then there was this womb wall that would sort of bounce back the legs. But if we don't have that boundary outside the womb, then we need to support the baby to bring back the legs. And the same with the arms. They can flare out like an airplane. And then we have to sort of look and say, oh, what are you doing? Flying around. And then you take a hand or you place your finger and you see if there is a grasp reflex. And when they do, you slowly bring the hand back to the mouth. And so you bring everything back to center very slowly, very carefully. And finger splays is also very much a sign that they are disorganized. And frantic, diffuse activity, you've seen it on the video, is when the environment is not supporting the baby any longer, when there is stuff happening that the baby is reacting to, either noise, sound, light, harsh voice, cold hands, anything can happen, and you want to be aware of what you're doing together. I am most scared when the baby sort of tunes out, when they lie there, they just couldn't care less, they're at the end, they're no longer responding to you. This is when the doctor says, oh, it's got a sepsis. And yes, we should be very mindful that it might be a sepsis, but you also want to see, so why is he sort of flat out? And when you have some very energetic nurse telling you that she's taking care of the baby and now he's all sleeping, you go like, is that sleeping or is the baby just at the end? And the sign that you want to remember is when you're working with the baby and slowly the mouth sort of like droops open. It's like, whoa. This is when the face becomes soft. That's one of the first signs. Of course, you've already noticed that the breathing of the baby is more irregular than when you started, and you see that the color is dark under the eyes, and then you see the mouth drop. It should be a signal telling you, okay, the baby's really had enough now. So then you want to decide, what do I need to do more that will keep him alive and happy? And it could be a diaper change or just evacuating saliva. But those are very subtle signs that will help you so that the baby doesn't go further and sort of like, whoops, drops their arms and their shoulders, and eventually they will stop breathing and they have apneas. And if the worst gets, then they'll have bradycardias as well. So again, you want, this is the states. I missed a slide here. So with the with the motor system, you want the baby to be in a flexed position. You want them to have their hands ready near the face so they can hold their face, or they can hold their ear, and they can hold their hand, and they hold a small object, and then they bring their legs in. We often forget the legs because we often only look at the top part of the baby and do not wonder where the legs are. So be mindful of the whole baby, please. State is always very difficult for us, for the non-psychologists in our audience. State is a range of 6 items. There's deep sleep, and then there's active sleep. There's state 3 is sort of, you know, the alarm clock has gone off and I have to go to a conference today. Oh boy, no, that's 5 more minutes. And then that's sort of a state 3. You are awake, but you're not participating in the daily goings on. And then you sort of wake up because the snooze button has gone off again, and you decide, okay, and then you open your eyes and you know where you are, and you get oriented and you start thinking, you know, what do I need to do? In my case, it's shaving. And then, you know, the knife is, there's something going on, and you're going fast. So state 5, you're actually agitated and you're a bit edgy because you have no time because you spend too much in a state 3. And then you get going, and then something happens in the hallway and you fall over and you're really pissed off. That's a state 6. You're really, really angry, or you're crying if you're a baby, or, you know. And so the thing is that with state regulation, you want to wake up slowly, you want to wake up gently, you want to transition from one state to the next in a very balanced way. And what we see in premature infants is sometimes they go from a state 2 into a 3, and then they yank into a 5. Because of whatever happened in the incubator or around the incubator. And they show the behavior of going from 5 to 3, from 3 to 5, maybe 6 if they're strong enough. They go back to 5 to 3, or they stay in 3 when they're more developed and they don't care what's going on, like their mommy is not there, there's so much light, you know, I'm keeping my eyes closed and I'm not participating, and what are you doing down there, changing my diaper again, whatever. And so you're not too happy, you're not having a fun time. And this is what is very important for us, is to go slowly with the baby and to see that the only interaction you can really have with the baby is when he opens his eyes and he is in a 4AL or a 4AH. And that's what is important. So when you look at the next one, yeah, I've seen you. But I do need to get some extra time for this hobble at the beginning. So you see, the thing is that FI care, family-centered care, having parents at the bedside, wow, you know, this is amazing. And we have instructed the parents, the mother's holding her hand there. But you see the baby's breathing is already irregular. And you see his skin color, he has some white patches, his darkness under the eye, his nostrils flare up really brightly. And then he's breathing irregularly, and he's sort of looking out. Again, he hears his mother's voice, he tends to look towards the mother, but then he sort of like goes back again. He has one erratic behavior of his arm, and he's really, now what's going on here? The breathing is still going very erratic. And he actually masters that, you know, he's sort of shielding himself. A big yawn to recalibrate, what am I doing, what's going on here? And yet he is curious. He does want to connect to the mother. I mean, social behavior, going to breast, it's all steps are already in there, but of course he can't do that yet. But he's trying his hardest. And then you get to the point where how much is it costing him to actually show this behavior? How much, you know, from the autonomic system is suffering so that he can use his state system to start looking? And is the looking still successful? I mean, you see his eyes wandering through his head, you know, and sort of, and the color is getting bleaker, and the breathing is more irregular. And he's sort of shielding himself some more and coming out again. The thing is, what is the baby telling us? The thing is, I mean, the mother is wildly enthusiastic because she says, it's like he's seeing me for the first time. It's like with my older daughter. She's looking at me. I mean, and there's this really build-up and connection. But in the meantime, his autonomic system is suffering. His motor system is sort of, you know, still these erratic behaviors. And when you really truly want to tell me what is going on, what should happen for the baby, is we should help him back to sleep. And yet, you know, we don't do this. We go on. We still enjoy what he's doing. Because for us, the eyes open are amazing. But for him, as much as he wants to, he needs us to down-regulate. He needs us to say, okay, buddy, you've done a great job, and now we're going back to sleep. Duh, I know you want to watch TV, but that's not happening. So we're going to help you go to sleep. And so we've seen the diffuse sleep and awake and the whimpering sound sometimes, eyes floating. Sometimes they have fuzziness or they have this sound that goes on when you lift the baby or you're working with. It's sort of like, you know, I'm not happy with that. And sometimes they get locked on or they stare or they're glassy-eyed. But you want to be mindful of these particular behaviors. And then you want to ask yourself, what does the baby want? What is he telling me? You know, I can teach you the language of a baby. That's not the big deal. But I cannot teach you to listen. I cannot teach you to listen. And when you listen, I cannot force you to do what the baby is asking you. You have to make a conscious decision. I'm going to work with this baby. And together we're going to manage. And it's not the Olympics. It's no big race. And he doesn't have to shine. But we have to enjoy the moment very quietly, very softly. And hopefully that the baby is enjoying this. And then he can look up and look at you. And then you can go down again. And he can sort of go back to sleep. So we need clear, robust sleep states, rhythmic, robust crying. Babies can cry, you know, they can protest. They can tell you, hey, come on, hurry with the food, or don't do this. So, and then for rewarding, if the baby's really into that phase, this ooh phase, is like, you know, this approach behavior, that's what you're aiming for, that they eventually will approach you, that they will have the energy and the regulation to open up to what's going on, that they will open up to the mother, to the nipple, to just being, you know, with the mother or the father in being held kangaroo care. If you look at your neighbors right now, you see some form of self-regulation. It can either be holding your own body, supporting your head, or a little yawn once in a while. These are normal behaviors that already start in the womb, actually. And sometimes, you know, we have our feet on top of one another, of each other, and that's self-regulation. And you also want to ask yourself, what is the ideal environment? And Linda Gilkerson of the Erickson Institute, she said, you know, babies, they need protection, they need predictability, restfulness, intimacy. They just need a very quiet life that is secure and helps them to start to trust, to train the amygdala further and have a little joy. And dream of going to the breast. This baby is actually 28 weeks when he did this. And we sometimes have a nurse who enjoys the baby and sort of, I get sometimes videos of little babies. Yep, I saw you. So he's holding onto the finger of the nurse and she's talking. And he looks away, sort of, so he's self-regulating a bit. He's trying to make contacts, but these are seconds, you know. He doesn't need to have an elaborate conversation with you. And, you know, he will look away. But in the meantime, you see his color of his face have white blotches and And so then you know, this is it. We now need to go to sleep. So why do we do this? Well, these babies are both, this baby and that baby, they're both term age. But this baby looks so much different from this baby who is with Dr. Al, Professor Al's, making contact. This baby wants to make contact too. You see the eyes, and it's costing him a lot, and he needs, regulation. Let's skip this. So, and the other reason why you want to load a language is when this baby, and Sonny and I saw this for the first time years ago, he said, you're doing a heel stick. So he recognized this behavior as sort of painful discomfort. And we made this film actually because this was years ago in our unit, they said, we do such good, beautiful individualized care, and we do it quietly and softly on the side, and we give, something to suck on with mother's milk. But in the meantime, this baby wasn't going to sleep. This baby was being gavage fed with gravity. So there was no one there to really watch the baby's behavior. There was no one there to support this baby. And we were seeing this behavior, and we were telling the people, you need to stay with the bedside because the baby can't do it on his own. And then I thought, why is he doing this? Why is that grasping behavior? What's going on here? And we realized that the mother's milk that was given had not been appropriately warmed. So this was cold milk that was going into the baby's esophagus, into the stomach. So the baby was reacting to cold milk. And when we showed this, we said, this is what's happening, and this is a stressful behavior. And when the baby is on 12 feeds a day, this will happen 12 times a day. So 12 times a day, this child will get a very serious, painful act done. And instead of enjoying the food, he's having bad synaptic connections made in relationship to getting fed. And so what we saw is, we need something to warm the food, and then we got him a good conductive warmer, and we changed our habits just by watching and thinking. You can change your care, and now we have beautiful care where the mothers, sit doing kangaroo care, and I'll be patient. So this is what we want, we want them to have the best experience, and when the baby becomes more motoric, the dad might stop the gavage feeding for a little bit. So this is feeding your baby together. This is trying to make the best experience that the baby can have surrounding feeding habits. And we often, we work with parents, we tell them, we actually have a book in our unit, and this book, the baby's sister, the older sister, is actually reading the book on behaviors and how you take care of the baby and what the baby needs. And the parents, the mothers, she sent me this video. And Monique, can you make a picture of it, because mother specifically asked. And what's happening here, the big sister is reading a book to her little brother. And when you look at his focus, it's amazing. He's really focused on what's happening there. And to me, this is true connection. This is what sister love and brother love looks like. It's a very short segment, and I promise you the baby, they really enjoy that together. I'm done. And so this is what we work towards, by appreciating the behavior of the baby, by recognizing the dysregulations of the baby, by then slowing down and supporting the baby appropriately and having the baby sort of catch up with you. Then you get to a point where you learn to sort of see, now is the time to connect. And even a bigger sister knows it, She can do it, so we can all do it. And the reason why we do it is because we have one brain for life. Everything matters, and in my case, NIDCAP is brain care. And I wish that for all the babies in the world, actually. Thank you for your undivided state 4B, your attention.
Thank you very much for showing these fantastic movies and pictures.
Thank you.
Every time I see them, it's like an eye-opener. I wonder, are there any questions from the comments from the audience? Well, meanwhile, I can say I've been together with Agneta Kleberg a couple of times watching babies, and I think it's really, every time it's like just standing there as a doctor for I don't know, 50 minutes or something like that, and watching a baby, you see so much.
One of my students actually said, sorry to interrupt, she was standing there and we were watching a baby, and I said, so what are you thinking? And then she said, yesterday I would have said this is normal premature behavior, and now I know it's dysregulation, it's disorganization. So sometimes we think it's normal the way some babies move, but it's not, you know, it's dysregulation. So by recognizing it, and you can name it, and then you can support the baby better.
We had Heidi Salz here 20 years ago or something in the unit here, and she was teaching people who were doing NIDCAP, and I was responsible for a child in a room, and she came up to me afterwards and said, well, I'm so worried about that baby. And I went in there, it was a baby, looked good looking, and I asked the nurses who were well trained, and I examined the babies, and I felt, oh, nothing, and stable, everything. And the nurses reported that everything was fine. And we said, well, we can't find anything. And then she went there the next day, again, watching this baby, and came back to me and said, well, I'm so worried about this baby. Something is not well with this baby. And I went back, and I examined the baby, I didn't see anything. The nurses told me, no, it's fine, everything is stable, and so on. And on the third day, the baby developed necrotizing enterocolitis.
Wow.
And she had something in her eyes that we couldn't see. But from that day, I must say, I'm very, very convinced that these eyes are so excellent.
That's also why it's so important when parents start to appreciate these meticulous behaviors, and that when I always get very nervous when the mother tells me there's something going on with her baby, and we together then we'll figure out what it is. And that's, you know, because in our unit, when we teach the parents and they become more appreciative of their own babies.
Do you think the babies are better regulated now when they are lying on their parents more than in the incubators?
Well, thanks for the question. I do think there is more to just skin to skin than meets the eye. It's also, is the mother or the father regulated? You know, if the father is nervous, or the mother cannot lie there and enjoy her baby or feel the oxytocin rushing through her veins, then you might ask yourself, is the baby better off on the chest of the mother? So I always think you need to sort of see the whole family situation. And I've many times talked to parents who were not able to do kangaroo care, who were not able to relax. And then, yes, then you want to work with parents and hear them, listen to them, and share some of what you know. Never blaming them, because they're on a journey that is far beyond anyone's comprehension. And then just to breathe with them and to be with them. And I've seen some excellent examples that the baby would actually make a physical turn after we've worked with the parents and after they have told us how much afraid they were, what they were worrying about and all that. And then after, you know, you talk to them and they were more peaceful, then the whole kangaroo care was going better. So yes, my aim is that they are together, but I do acknowledge that sometimes it's difficult.
Do we have any more comments or questions? I think did you? Yeah. Hmm?
Thank you so much. This is so interesting. I was so happy to hear how you use your voice when you approach the baby. I think we can all really learn from that, and also it's a way of activating your empathy. I mean, oh, are you tired? I would be too if I was laying here. I mean, that approach and warning the child that you're approaching. It's
one of my students, she actually verbalized everything,
yeah.
and I thought it was really weird.
Yeah.
This was a long time ago. But she would say, because I said, so why do you talk out loud? And she said, well, I don't know what to say otherwise. So she would mention what she was doing to the baby, and then they would talk together. Sorry, I interrupted you.
No, but that's just great. Yeah.
Thanks.
Yeah. And then I have just a comment on when it's maybe not good for the child to be in the kangaroo care, because I sometimes talk with parents that have like traumatic experiences, and there was a mother who couldn't. She'd been she lost her mother a few years earlier, and she was afraid of the child if it would stop breathing. Mm-hmm. So we had to go through that very carefully with the staff and keep it open, so the staff, so she felt connected to the staff, not closing her in the corner of the room.
Maybe I can make one last comment that happened in our unit. When we have mothers who have severe medical problems, and with the corona crisis, we had a mother who was in the intensive care unit, and then she had to be C-sectioned because they needed to rotate her, and otherwise they couldn't ventilate her anymore. So the baby was born at 27 weeks. Just involuntarily, just taken out of the mother in order to save the mother. And then what we do, and the intensive care unit is sort of far, but we took the transport incubator, put the baby in, and then bring it to the mother, and we would place the baby on top of the mother. If she were then on her back at that moment, we would coordinate this. So we placed the baby on top of the mother, and the mother was in an induced coma. And what we saw, and we have it on video as well, is that after half a minute or so, there was a tear running from the mother's eyes. So this is, I mean, to me, that's the awe of nature, that even if she is under medication, that she still realizes what's going on. And if you talk about love, I mean, there's no better example, I think.
Okay.
Thank you.
Well, thank you very much for a fascinating talk. And now I'm